Our second speaker is Professor Saeed Mahar. He's Professor of Endocrinology at NICVT Karachi. He's also Director Academics at Vice Academy Pakistan and past President of PES. He will present on female infertility, role of an endocrinologist. So let's welcome Professor Saeed Mahar.
Thank you very much, and I'm really humbled and honored to be once again here, and I'm grateful to Dr. Aisha for his kind invitation, Dr. Ali Asghar, the scientific chair, and Dr. Faisal Masood for the wonderful arrangements during the scientific session. I will try to finish in time because I know I have got 20 minutes. So this is the topic which is being seen by the multidisciplinary teams. It's not only that we endocrinologists see, the gynecologist colleagues also see, and then the fertility specialists also see. These are the learning objectives that what we learn at the end of the presentation. Infertility, we can describe clearly, diagnostic approach, and some of the common management issues or the how to deal with it. If we go to the infertility definition, that it's inability to conceive, as per the US definition, it's the 12 months, but for the Europeans, it's actually the 24 months. So the Americans are in a hurry, but Europeans are not. So they have to wait at least for the 2 years before you can label it that this is infertility and that need to be investigated or treated. Infertility or subfertility, it's around 10-15% of all couples seeks specialist help, and 1% of the pregnancies require ART. Dr. Richard has actually made my life so easy. There's so many things that he has already explained. Thank you, Richard. Now, if we classify it, the 80% are the normal, but superfertility, more than beyond that, 3%, and subfertility is 10%. Subfertility or absolute infertility is again about 7%. Start with a case that how we do get the patients in our clinics. A couple attend the clinic with inability to conceive after 6 months. Both partners are healthy. They are on no medications, no past medical history. Female has regular menses and normal physical examination. Male has normal physical examination, including the testicular size and presence of the vas deferens. He has normal testosterone, LH, FSH levels. So, what is the likelihood that he would conceive in the next 6 months? Any guesses from the audience? What do you think? A, B, C, D, E. E. Okay. C. It's around 50 to 75% chance that this couple will the female get pregnant and they don't have to go to any of the specialists. Now, if we look at the monthly fertility rate, 20% is actually the normal, 75% of the normal couples pregnant at 6 months, and remaining 75% pregnant in the next 6 months. And all couples who have pregnancy at the 24 months, as I said earlier. Moderate subfertility is 5% per month, 25% pregnancies at 6 months, and further 25 pregnancies at the 12 months. Now, it's not only the female which has got the issues with the fertility. Keep in mind that around 25% has got the male factor, 30 to 40% is the female factor, and 30% is the combined or unexplained factor. So this is not only the male or a female issue, but sometimes it's the combined issue or sometimes it's unexplained. Now, we are going to move to the management of the cause of endocrine. Have the second case is a 35-year male, a 31-year female, inability to conceive for 1 year. He fathered the child from the previous marriage. Examination of the male is normal with normal seminal fluid analysis. Gonadal axis. Wife has regular menses since puberty, mild hirsutism, and normal pelvic exam. Most likely cause of their infertility is A, B, 1, 2, 3, 4, 5. What are the guesses from this case? 2? Very good. Appreciate. So, most probably the female has got the polycystic ovarian syndrome, which is again one of the common things we do all see in our clinical cases. Now, if we go to the basic evaluation of the female, definitely what we have been learned that this is the history, physical examination, then the pre-pregnancy evaluation, and some of the extra investigations like the investigation for the ovarian reserve, tubal, or uterine factor. So this is not again saying the gynecologist, fertility specialist, endocrinologist, they all work together in these cases. I will focus more on the endocrine issues. So it may be the hypothalamus, pituitary, thyroid, or the ovaries that are the main targets. So if I go to the hypothalamus, then hypothalamic lesions that can result to the decreased GnRH secretion and amenorrhea. I think so. Professor Richard has really nicely elaborated all these. So these are one of the reasons. Number 2 is the pituitary gland. Now pituitary gland, the most common things, what we do see is actually the prolactin levels. We do see the patients with the increased prolactin levels. Now, what actually causes the hyperprolactinemia? Hypogonadism, infertility, galactorrhea, bone loss. So these are actually the some effects of hyperprolactinemia in these patients. Now, what is the base test? A base test is simply measure the serum prolactin level. If you're in doubt, you always can repeat the serum prolactin level with a small gap within a few days. So if you look at the prolactin levels, you get a fair idea that's what's wrong with them. Now, if you look at the graph, this is the first, this is the macroadenoma. Usually with the macroadenoma, the levels are in thousands, from maybe 400-500 to the thousands. But with the macroadenoma, the levels may be around 100, 200, 500, little less. Then other pituitary thalamic disease, not very high. Pregnancy, again in the middle range, then stress and drugs. Another thing which we always miss and which I have learned from my teachers, Professor Jabbar is here, he is one of my teachers in my fellowship, that start first with the history. And majority of the patients what we seen with the high prolactin levels, they have got the history of PPIs, the other drugs that actually rocket high your prolactin levels. So you just do nothing. Don't go for the expensive test. Just stop these drugs and ask them to repeat in 3 to 4 weeks. And you got the answer. Instead of putting that patient into an expensive MRI and the drugs, just repeat that and then see. Another common problem with the high prolactin level, which you always keep in mind, is the hypothyroidism. Whenever somebody is coming with these two things, you can really appreciate that what the problem is. Prolactinoma management, I think so, dopamine agonist are the best drugs, cabergoline, which we endocrinologists frequently use with convenience of once weekly dosage, better results, better tolerated than the other drugs. How you follow? We need a periodic prolactin level to these patients, maybe once or 6 weekly. Then you can further adjust and you go check for at the 3-month level, and then maybe annually, depends on your patient, that what your patient is. Coming to the growth hormone, I don't touch into detail the growth hormone because just for the sake of my junior colleagues, that growth hormone excessive causes the acromegaly, and this could be the cause of the infertility in females. Then another thing which may cause the infertility is the SCTH, which is the Cushing syndrome, and these are the classic pictures that patient may present of the Cushing syndrome like that. Just to keep in mind, this may be one of the reason for infertility. Then coming to the thyroid gland, which we do again see very commonly, hyperthyroidism. I don't want to go into all details, but definitely hyperthyroidism also causes actually the infertility. Majority of the patients will present to you with the tremors, the nervousness, difficulty in sleeping, weight loss. These are the most common things, and again, some may land with the impaired fertility. The opposite of it is actually something which we do more commonly see is the hypothyroidism, which is again one of the cause for infertility. Then again, they come with the tiredness, the weight gain, the irregular periods, and for example, difficulty thinning of the body hair, and all these cold intolerance, they are the common symptoms of hypothyroidism. How to look into these two main problems? Thyroid problem, just simply go for the TSH. If you are looking for the infertility, then definitely just have the TPO antibodies also. If the TSH is more than 2.5, then and patient is looking for the fertility, definitely you have to go for the levothyroxine. Then if the TSH is 0.25 to 2.5, antibodies are negative, just follow them. But if the antibodies are positive, you just put them on a small dose of thyroxine. And again, if the TSH is low, 0.27, and then again the free T4 is high, then definitely the anti-thyroid drugs, or depend what the other modality you choose. But if the patient is planning for the surgery in the near future, usually we don't put them on, you advise them for the radioactive iodine ablation therapy, where you have to wait at least for 9 to 12 months. Then the ovaries, another common is actually the polycystic ovarian syndrome, which I discussed earlier, is actually one of the common issue with which about 70% of the women, they may remain undiagnosed, and this is again one of the common issue for the infertility in the females. So how you diagnose? Again, a triad of oligo or anovulation, then actually the polycystic ovaries and hyperandrogenism. Now, the oligo or anovulation, either you document it or you can ask the patient from the history. They will give you the history of irregular periods. Then again, hyperandrogenism, you definitely look into the testosterone levels, the androgen level, the androstenedione and the DHA sulfase. If the total or free testosterone are not elevated, you just have a second thought to these, that why they have got the irregular periods in these patients. These are some of the pictures that usually you do see in your clinics. They come with the acne, they come with the alopecia, and they come with the hirsutism. So this is one of the common presentations that these patients come to your clinic with the main complaints of infertility or irregular periods, weight gain. Okay, how to treat it? Now, I will again say this is something which is very pertinent. Majority of the patients who come to your clinic with the polycystic ovarian syndrome, they are obese. So if you just do one thing before anything, you try to explain them that if you lose the weight, your 50% of the problem will be resolved. So the first thing is that definitely we'll go check the blood glucose, weight, ask them to do not smoke, alcohol abstinence, diet, proper sleep, exercise. Then we definitely say for the weight loss. Then the first thing is that nowadays letrozole is being used in these patients. Then we all do use the metformin or the combination of these two. Then the second line pharmacological agents, if they are not working, then definitely we add them with the gonadotrophins in these patients. But again, I'm repeating it again for the sake of my junior colleagues, that in these patients, if these patients are treated in a way that they lose the weight with the management, definitely they've got very good results in their fertility. Now, how you work up for the infertility from the endocrine point of view? Infertility, history and physical examination. Then, as I said earlier, TSH and anti-TPO antibodies. Yes, you can check the FSH, estradiol, and the prolactin in these patients, and that depends how the results are, and then you move according to these results in these patients. Now, FSH, estradiol, FSH is increased, estradiol is decreased. This is again hypergonadotropic hypogonadism, or what we call as a primary ovarian failure. Decrease FSH, decrease estradiol. Professor Quinton has beautifully described it. Hypogonadotropic hypogonadism, then definitely you need some of the more specialized tests. You need the pituitary to be imagined, and then if the FSH is normal, estradiol is normal, then definitely you need workup, what I have already discussed, that check there for testosterone level, polycystic ovarian syndrome, other endocrine causes like again the prolactin level and all these. You exclude all these in these patients. So this is something which is a basic workup for the infertility when someone is coming to you in your clinic. To summarize, that the evaluation of female infertility must consider the etiologies other than the ovarian and uterine abnormalities. So it's not only the ovarian and the uterine abnormalities that causes actually the infertility, but as again I'm shown you the other endocrine problems that which easily being treated or actually the cause of the infertility in some of the patients. There are common endocrine disorders that manifest with infertility due to hormonal changes. And again, I'm repeating the same things, maybe simply a patient who has got hypothyroidism, you simply treat her hypothyroidism, I assure you that the chances of fertility will be increased so much, and there are so many patients that they have responded very well. Once you make them euthyroid, they have got great chances of fertility without sending them to any infertility center. Just on a lighter note, because I'm seeing I've got 2-3 more minutes, there's a endocrine or infertility center in Karachi, I don't want to name it. They used to send me the patients for hypothyroidism, and I do see a lot of them. And suddenly I realized that there are no further patients from that center. I don't know why, what happened. So one day, one of the junior colleagues, senior to baat nahi batate, one of the junior colleagues, which were my trainee also, I met him some conference. मैंने कहा बेटा आपके सेंटर से मरीज नहीं आते हैं, क्या जरा आप मरीज को ठीक कर देते हैं, हमारा धंधा मारा जाता है, तो हमें मना किया गया डॉक्टर सईद के पास नहीं भेजना है. So when you treat their thyroid, they become euthyroid and become pregnant. So how we will mint money when we treat them for the infertility? So they stop sending me the patients. I don't mind it. So it's up to you. So this is something which is the real world that they can do like that. Okay, the management of endocrine causes of female infertility requires prompt identification and targeted management. So this is something that if we work together, it's not only one-man show, that if we work together, then definitely we can give a good response, or we can give the good management to our patients, and that actually enhances the chances of fertility without going into very expensive treatments. I think so this was my last slide. So take care of the women, take care of the future generations. Thank you very much.